assistance and programming to USAID field missions and PEPFAR country teams. He's responsible specifically for synthesizing cutting-edge research and best practices regarding HIV prevention, care, and treatment, and their application to USAID and partner programs. Tim was previously director of the USAID Health Office in South Africa, where he spent several years, and also travels back frequently, overseeing, as we know, one of the largest PEPFAR portfolios in the world. Before that, Tim was a research fellow at the Harvard Center for Population and Development Studies, and also a visiting scholar at the University of Cape Town. Before that, he was a Peace Corps volunteer in the Gambia and received a Master of Science and Doctor of Science degrees from the Harvard School of Public Health and his BA from the University of Pennsylvania. I'm really pleased that you came up from New York to share the perspective on USAID. Tim's going to talk about developing and implementing data-informed HIV programming at scale.
Great. Good afternoon, I guess. Great, yeah, so thanks for having me. Please feel free during the presentation to interrupt whenever you'd like. I'm happy to talk through things. I have about 40 slides. A lot of it is really data intensive, but the point isn't to actually dive into all the data. But what I wanted to do was really talk about some of the work that USAID does. So I work, again, in the Office of HIV and AIDS, so I work on PEPFAR programs. And right now, my portfolio globally is around key populations, so looking at our sex worker, men who have sex with men, people who inject drugs, and transgender programs. I also oversee our Orphans and Vulnerable Care program. And then my sort of other part of the portfolio is that I'm what we call our Senior Country Associate for South Africa. So I'm the primary connection between our headquarters office in Washington, D.C. and our South Africa country team. So just to give an overview, you know, I don't know how familiar people are with PEPFAR and USAID, so I'll just give a little bit of a background about the organization that I work in, and then really talk about interventions and thinking about the right people in the right places and the right interventions. And then I'll try to get back more into the sort of academic research side of things in terms of implementation science, and then looking at two interventions that we're heavily focused on in PEPFAR. So HIV pre-exposure prophylaxis and then ART multi-month dispensing. So just to start with some key messages, you know, one of the things that PEPFAR has done over the years is really started to move towards targeting the right people in the right geographies with the right interventions. And it's a mantra that we hear all the time. Historically, if you look at the way PEPFAR programs or more broadly development programs have evolved, we haven't always gotten all of these different pieces right. In times of declining resources, getting these pieces right is incredibly important. And then the second point is around program data and research data. PEPFAR is an incredibly data-driven program, and it really does influence implementation, and increasingly on rapid timelines. So the oldest data or sort of citation that I have in here is 2016, and the most recent is from last Friday in terms of data that I'm looking at. So this is an incredibly different mindset of how we look at data. You know, I look at the DHS surveys and I think, you know, even the most recent one from 2017 is probably too old for PEPFAR now. And so it's really developing a new way of doing business, particularly in the development sphere, and how we utilize and look at data. And then the third piece is, you know, I came out of academia and on a research perspective, and have been on the program side. And it's incredibly important to understand how programs work in order for research to really be utilized for implementation. So we see a lot of research that comes out that it's either the field has moved years beyond where that research was because the question was designed 5 years ago and it took 4 years for the study to be completed, and then it's not very useful for us. So really thinking about how we understand programs as they're implemented. So just a bit of background. So USAID is the world's premier international development agency, and is a catalytic actor at driving development results. So we really think about advancing U.S. national security, economic prosperity, and demonstrating American generosity, and promoting a path to self-reliance and resilience. So I work for the U.S. government, so hopefully I won't say anything controversial. We will not talk about any politics here. So PEPFAR. PEPFAR is the President's Emergency Plan for AIDS Relief. It was authorized in 2003 by President George W. Bush. It lasted through the Obama years and is now into the Trump years. So this has been an incredible bipartisan effort. Interestingly, when it was started under George W. Bush, HIV is this incredible sort of political thing where you can sort of appease everyone on the right and everyone on the left. So you have this bipartisan support that has really endured. So it's been an incredible investment of the American people. To date, there's been over $80 billion invested in PEPFAR. And these are the results from World AIDS Day last year, so 2019. So in green there at the top, or I guess it's blue, it's hard to tell with these colors, but over almost 16 million people are on ART as a result of PEPFAR. There have been more than 22 million circumcisions, and right now we have more than 6.3 orphans and vulnerable children who receive support from PEPFAR programs. So often it's hard to understand what exactly PEPFAR is. So PEPFAR is an initiative that is funded through Congress. We report to the US Global AIDS Coordinator, which is out of the Department of State, and that's Ambassador Deborah Burke. She's now also in charge of coronavirus, so you probably there was just a New York Times article today profiling her. But she has been in charge of PEPFAR. And PEPFAR, the way the funding flows is it goes through the Department of State and then into 7 different agencies. So the 2 largest implementing agencies, the US government agencies, are the Department of Health and Human Services with CDC and USAID. But we also have funding that flows through the Department of Commerce, Peace Corps, the Department of Labor, Treasury, and the Department of Defense. So this is, if you work in the HIV world, this is something that you should all be familiar with. This is the UNAIDS and the global sort of goal of 90-90-90 to treat all. So it's ensuring that 90% of people living with HIV know their status, that 90% of those who know their status are on ART, on antiretroviral therapy, and that 90% of those on treatment are virally suppressed. So again, these are World AIDS Day numbers from December 2019. So about just almost 38 million people living with HIV, 79% knowing that they're HIV positive, and 53% of those living with HIV have undetectable viral levels. So now diving into some of the meat of the presentation. So in large and diverse epidemics, how do we maximize limited those substantial resources? So obviously $80 million over 17 years is a huge amount of money, particularly when we think about it in terms of public health. But how do we make sure that these resources are utilized in the best way? So again, it really is this mantra of right places, right populations, and right interventions. And we are using data heavily to identify what these all are. So this is the oldest citation that I have here, and I really like the visual of this. So the global burden of HIV is not evenly distributed, and 90% of PEPFAR resources are programmed on the African continent. So obviously here you see that South Africa, it has the largest epidemic. Again, these are old numbers. At this point, it was in 2016, it was 7.1. It's just about, I think the modeling numbers from last month were about 7.8 million people living with HIV. But the biggest PEPFAR programs in the world right now are South Africa, Nigeria, Kenya, Tanzania, Uganda, Mozambique, and so also sort of very much aligning with the geography of the epidemic. So this is one way of thinking about how PEPFAR, or how we can think about resource allocation. Here's some data again from 2019. In sub-Saharan Africa, 3 in 5 new HIV infections among 15 to 19-year-olds are among girls. So that large dot on the right-hand side, the biggest dot there is South Africa, 4.1 million girls and women living with HIV. Again, so moving from the sort of geographic sort of thinking about where countries, where we need to put resources for countries, this is really thinking about, okay, even within a country, what do the populations look like? How do we need to address the issue that's happening, particularly among young women. So these are data from South Africa. Again, this is the portfolio that I work with most. So this is modeling data using data that was sort of ending in October of, so the last fiscal year for the US government, so October of 2019. So what you see here is a sort of a PLHIV pyramid. And the dark orange and dark blue are those who are on HIV treatment, and the overall bar is the number of people living with HIV. So one of the things you can see is, one, burden is obviously heaviest among women, and it's highest in women 25 and older, and in men 40 years and older. And we also see that there's the lowest coverage of ART among men 20 to 24 and 25 to 29. And on the right side, it's really thinking about who's not on ART. So who as a program do we need to be thinking about in terms of targeting our programs? So again, these are data that we just used in South Africa. I was there 2 weeks ago, that we were looking at to define what the program is looking moving forward. And we have literally hundreds of slides that look like this that are really diving into the data, because it's the South Africa program this current year. It's a $750 million program, but it's still not enough resources to really cover everything that we need to do in this context. So this is, again, from the same sort of sets of data that we're looking at. We're really, as PEPFAR, we're continuing to invest where the burden is highest, even at the subnational unit or subnational level. So all the sort of columns here are different districts in South Africa. So on the right, you have the heaviest burden districts. And so the largest district is the city of Johannesburg, with almost or a little over 700,000 PLHIV. And just for sort of context, the country of Lesotho has 340,000 people living with HIV. Botswana has 370,000. Malawi has 1 million, and Zimbabwe has 1.2 million. So in just the city of Johannesburg, you essentially have the entire country of Lesotho and the entire country of Botswana in that one city. If you look at, for those of you who know the geography of South Africa, Johannesburg and Pretoria are right next to each other. So these three light green colors here on the left side of the graph, those three are essentially the Johannesburg and Pretoria areas, and then the area in between the two cities. And if you look at those numbers, it's almost 1.5 million people. Again, just to think about the scale of the epidemic that South Africa is dealing with. So this slide shows the most recent data that I have. So this is data as of last Friday, so February 28th. In South Africa, we collect daily data on a subset of about, I think we're around 425 sites that we collect data on a daily basis. It's reported up to our field team up to headquarters, where I'm at, on a weekly basis. So this is really looking at the number on a weekly basis or a bi-weekly basis, the number of people that we've, the net new on treatment. So this is the number of people that we've started on treatment minus the people that we've lost because of loss to follow-up, retention issues, and things like that. So again, this is something that is completely unique to PEPFAR and where we have moved in terms of the response. I mean, I look at, we're looking at what's happening at a clinic level from last week. And this is a clinic in potentially the middle of, the Durban area, and we know exactly what's happening less than 2 weeks later in Washington. So the ability to really dive down and understand what's happening in a program is incredibly intense. Obviously, there are lots of challenges with trying to collect data at that level. One, there's a lot of data issues. Two, it's incredibly intensive to collect this amount of data and on this frequency. And if we're not utilizing the data, it's a massive waste of resources. So this is, again, looking at that at the sort of the lowest level at the site. So these are the top 15 sites that have had the largest growth in treatment. So getting the most number of people on treatment over the last year. And again, this is looking at individual clinics, so we have a sense of what's happening at an individual clinic. And why is this important? Again, with limited resources, we have to understand how are we, the target for South Africa is to get 2 million, well now about 1.5 million people over the next year. When you say that number, that it sort of, at an operational level, it doesn't mean anything. But when you drive that down to a site level, what does each one of these clinics, how many people does each one of these clinics have to identify? How many people do they have to test? How many people do they have to make sure they keep on treatment? How many people can they afford to lose from the treatment cascade? That's the only way that a number like 1.5 million can actually get translated into programs. It has to, you know, a program manager at a facility has to understand what is his or her role and sort of contributing to a 1.5 million number. So again, it really is allowing us to target down to the individual facility and understand what needs to happen in a particular facility. If we see that, let's see, back on this one, if you look where sort of it dives below zero, this line here, that's the holiday period. For those of you who have worked in South Africa, essentially all of South Africa shuts down for the holiday period. And that's when people go on treatment holidays. They are traveling back to their homes. They're not picking up their meds. So it looks like they've fallen off of treatment. But then right after the holidays, when everyone gets back, you see that massive jump up again. So again, understanding what the trends are. So now what the program is trying to do really is to think about, okay, how do we make sure that that dip doesn't happen every year? We see this, we know this happens anecdotally. So maybe, you know, in the weeks of late November, what we would do is we may give next year, as we move into the holiday period again, we may give people extra supplies of drugs so that we can market it in their charts so that we would know that we're not actually losing people. So it's being able to understand some of these trends that allow us to adapt our program. Okay, so now jumping into some implementation research and science. And this is really sort of at the crux of the work that I do, and hopefully a lot of the work that happens here in terms of thinking about intervention science. So I don't want to go through these different definitions, but one of the things that sort of emerges from some of these definitions is it's really about thinking the way that these different definitions from NIH, the National Center for Complementary and Integrative Health, and the Fogarty International Center, it's really about integration of evidence-based into practice. So it's really thinking about how do we take research and how do we apply it or integrate it into the work that happens at a clinic level or in a public health setting. This is another framework. Just to say that there are a million different frameworks that we all use from different fields to think about how we approach implementation research. And so, of course, being a good academic, I want to propose my own. And so sort of starting on the right here, we really think about implementation from an individual level. So a patient comes into a clinic, how are we addressing that individual person's needs? We also think about the dyad, the couple. So when we think about, particularly with HIV, we're thinking about sexual partnerships and sexual couples. How do we, if we have identified an HIV positive person, how do we ensure that we can get their sexual partners tested or their families tested? So really thinking, again, at the individual level. So, you know, the research questions there are lots of research questions around what needs to happen at the individual or the dyad level. And then, of course, thinking at a sort of broader population level, but really thinking about communities, thinking about, again, at the individual level. Why is a person going to or not going to go for testing? Why is a person going to start on treatment? Why are they going to bring their child in for treatment? Or why wouldn't they bring their child in for treatment? And then there's the more systems piece. So thinking about commodities and supply chain. Do we have stockouts of ART drugs? Do we have condoms in all the places that we need them to be? Do we have TB meds where they need to be? Thinking about the data systems. In South Africa, it baffles me, but the data system in South Africa, the tier.net, essentially the health system there, in order for us to collect sort of if we as PEPFAR or the government wants a data call and has to understand what's happening for a particular issue on a quick turnaround, someone literally has to go to every facility with a flash drive and collect that information and aggregate it. This is a health system that's supposed to be managing by next year almost 7 million people on treatment. So it's incredibly challenging to think about that. So, thinking about different levels of the health system. So, all the way down from a community health center to very sophisticated hospitals in South Africa. So all of these questions influence and impact how an individual or a dyad or a community accesses services, whether it's for HIV or for other medical issues. And then thinking about healthcare workers. In South Africa, there's lots of different cadres of healthcare workers. How do we maximize our resources to make the investments in healthcare workers that's going to reap the most benefits in terms of getting people on HIV treatment? And of course, all of that is influenced by national health policy, operational plans, and subnational unit operational plans. And again, so all of these are cascading to the individual experience of a health service at a community. And then, of course, we have the Ministry of Health or the Department of Health in a country that is sort of putting out all of these national plans, which is then influencing the purchasing of commodities or the health systems, the information systems that are used. And all of that is influenced by organizations like WHO in terms of normative guidelines that they put out. It's also influenced by multilateral and donor organizations. If someone else, in a lot of countries, if someone else is paying for it, it can be a high priority, whether or not the government likes it. In South Africa, it's a really interesting place. It's the only country that PEPFAR works in where the national government actually spends significant more resources than the US government. And so the ability of the US government to leverage the HIV response is much smaller than it would be in some other countries. But this is really this framework is really to think about when we're thinking about implementation science and research that's meant to influence research, we have to be thinking about all these different levels. And so I want to talk about two interventions in terms of how that framework plays out. So the first is PrEP, pre-exposure prophylaxis. So just starting with the basic science here. This is a graph showing the effectiveness of PrEP across different clinical trials. And the punchline is essentially that PrEP works if you take it. So there's plenty of science that has said it works, it doesn't work, but what we see is if you take it, it works. But that nugget of a truth is incredibly hard because clearly people weren't taking it during some of the trials. Then you see very low, detectable levels of drugs and very low effectiveness. And how that translates into real world practice is incredibly important. But we sort of start with the basic science that this intervention works if you can get people to take it. So why hasn't it worked, or what have been the bottlenecks? So again, looking at some of these questions, and again, I'm most familiar with South Africa, but who can access PrEP according to national policy? So in South Africa, the way that the National Department of Health wanted to roll out PrEP was we want sex workers to get it first, and we'll see how that goes. And then we'll give it to men who have sex with men, and we'll see how that goes. And then we will give it to adolescent girls and young women and see how that goes. So in South Africa, it is not readily available to anyone who just wants it. People would never be denied PrEP if they asked for it, but it's not actively promoted to any of those populations. Kenya did it completely differently, I think. They essentially said, let's put it out there and let's see who comes for it. And then you can, instead of the national policy saying focus in here or there, it's the demand creation that's different among different populations. Who's paying for the drug? So, one of the conversations that we had with the National Department of Health in South Africa was this worry that if you roll out PrEP, it's, a dose of PrEP is the same thing as a dose of ARV. Is PrEP going to steal from my ARV supply because I need that? So who's paying for the drugs? In South Africa, Gilead joined a partnership, and they, for the first 2 years, supplied all of the, or a significant amount of the PrEP resources or PrEP drugs for South Africa and several other countries. And how does global guidance influence country level policy? So do we make PrEP available to pregnant women? There's some controversy there. WHO issued guidance. And do departments of health always listen to WHO? No, they have their own researchers, they have their own influencers who are deciding what pieces of the WHO guidance to implement into their own guidance. So that's at the very macro level, thinking about, so what are the bottlenecks, what are the issues that we need to address to make this all work? And then thinking more on the sort of the systems level, or at the facility level, thinking about, again, clinical protocols to facilitate uptake. We saw in South Africa, when we started rolling out PrEP among young women, a lot of clinicians didn't want to offer young women PrEP because they shouldn't have been having sex. So what do the clinical protocols say about some of the issues? Where are the drugs coming from? Again, this is not only related to who's paying for it, but the supply chain. If we're not offering it anywhere, how do we integrate PrEP drugs into the supply chain? If we have them in incredibly rural areas, what does it take? What are the resources that need to be put into place to allow that to happen? How do we monitor uptake? We want to roll out this incredibly effective intervention, but how do we know if anyone's actually taking the drugs? How do we know when people are stopping the drugs? How do we know if there have been adverse events? We don't have, at the beginning of the program, this is a novel intervention, we didn't have any indicators to understand sort of what was happening. PEPFAR and a lot of the normative bodies really had to think hard about, what does PrEP uptake mean? We don't want people to be on PrEP forever. So what does it mean if someone stops taking PrEP? Is that a good thing or a bad thing? How do we differentiate when you're just counting the number of people who take it or come off it? And then again, at the individual level, what implementation models will work for different populations? So the way to get men who have sex with men onto PrEP may be completely different, and is likely completely different than how we would talk to a young woman about taking PrEP. And how do we know which of these models is working? PEPFAR, for a couple of years before PrEP was officially rolled out, was doing a lot of this research, funding a lot of this research to understand how do we, when the time comes and we're at the start line and can press go, how do we know, which models are going to work? And until you actually have the drug and can actually do the work, it's really hard to do that type of research. Where should PrEP be distributed? Again, do we think that the clinic is the best place? Is it a mobile clinic that's the best place? For female sex workers, it's often a mobile clinic that seems to work better than a fixed clinic. For MSM, it may be a particular drop-in center that works better than the local facility. So really understanding for different populations which is going to work best. How to disseminate knowledge about PrEP. Again, this is a novel intervention. When you work in this space, you hear about it all the time. You go into a community and people have no idea what you're talking about. So how do you disseminate information? One of the challenges we often see is governments don't want to create demand before a product is in place. But you also don't want to have the product in place and then no demand, because then it just sits there. We had a lot of problems around the female condom early on, that we didn't create the right demand, we didn't create the right information about the product, and then it lagged. And once you start having lag, it's sort of a self-fulfilling prophecy that it's going to be really hard to get uptake. So how do we think about knowledge dissemination in a way that finds that balance of you don't want to create demand before the product is there, but you also don't want to wait till the product's there and then you're too late. So again, best methods for demand creation. In South Africa, it's an incredibly sort of mobile phone rich environment. Younger people have access to all types of social media. So what are the best methods for creating demand? Is it over community engagement? Is it on social media? What are the different methods that we can use to create this demand? And then even a more basic question is which target populations? There's been a lot of modeling work to understand if we roll it out among certain populations, will we have a bigger bang for our buck? But again, one of the challenges we had in South Africa, it was rolled out among sex workers first, and as it started opening up to other populations, it was associated with sex workers. Sex workers said, well, why are you only giving it to us? Are you trying to kill us? Is this a drug to kill us? And then we had at the other sort of a year down the line, we had adolescent girls and young women who were saying, well, why do you want to give it to me? I'm not a sex worker. And so how do you, if you are rolling out to different populations, how do you think about some of these challenges? So this was a project that was funded by USAID, the Options Project, and this was really thinking about preparing for PrEP. And sort of the utilization of PrEP, what I've been talking about has been oral PrEP, but I'll show you a little bit later, we're talking about lots of different pre-exposure prophylaxis. But this was really, this project really looked at all the different aspects of how do you roll out a novel intervention. And we've done this before across all different public health interventions and novel treatments and things like that. But it really was trying to put some kind of method around what are the questions that you need to answer as you roll out as a national stakeholder. If you're a government, if you're Lesotho, how do you answer all of these questions? How do you address all of these issues? If not, you're likely to run into some kind of problem when you start this intervention. So here is, again, data from, so this is the fiscal year, these are fiscal years for the US government, which starts in October. But the important piece here is the blue line, which is uptake of PrEP among MSM. In the summer of, so this is November of 2018 about, the Summer of PrEP campaign initiated. And so for almost a year, we had really sort of level uptake of PrEP. And then you do this kind of demand creation and we see it skyrocketing. So Q2 of FY20 is, what is that? So a month and a half ago. So we see over 6,000 men who have initiated PrEP in that time. This is also looking at data. So the last bar there goes up to October or the end of September of 2019. And you can see how quickly or how slowly, depending on how you view things. But it's a pretty incredible curve upwards. So in that one quarter, there were almost 15,000 adolescent girls and young women who initiated PrEP in South Africa. And sort of what were we doing? There are lots of different pieces, but earlier on in the presentation, I showed a slide that had sort of the incredible burden among women and girls. One of the sort of hallmark pieces of PEPFAR is called the DREAMS program. And this is a program that is really addressing prevention among adolescent girls and young women. But that started several years ago, about 4 years ago. And what we've been able to do with PrEP for this population is integrate PrEP into that program. And so what we're seeing now is an incredibly large uptake among adolescent girls and young women. So this is, again, zooming back out even further. This is looking at all new PrEP initiations by fiscal year. So in FY17, so that's 2017 into 2018, we had just about 22,000 people globally who were started on PrEP under PEPFAR. This past fiscal year, ending in October or ending at the end of September, we had about 163,000 people. And this current fiscal year, the goal is about 300,000 people globally. And for our next fiscal year 21, so the year starting in October of this year into the next year, the goal is to have 1 million people on PrEP. So you can see a pretty incredible trajectory for PrEP. And obviously on the right there, this is looking across different countries or OUs operating units for achievement of new initiatives on PrEP. So thinking about the next phases of PrEP, so how can implementation science help to address some of these challenges? So this is an organization called AVAC. Hopefully you've seen some of their work. If you work in the HIV field, they're really good with infographics and taking incredibly complex clinical trials and information and making really good infographics. But this is sort of the pipeline of biomedical prevention research. And so we have, several different technologies that we're thinking about that are in the pipeline that we hope in the next couple of years, we really are starting to roll out different options so that, women and young girls, men, anyone has a choice of different prevention methods to use rather than just a pill or a condom. And, it's thinking ahead again, what does, for the long-acting injectable cabotegravir, how do we roll that out? How do you get someone into the clinic every 3 to 6 months to get an injection that will provide protection from HIV? How is that different than a daily pill? What is it? What are the implications in terms of who will uptake that intervention? And again, this is just looking at different approaches to address bottlenecks and what are the questions that are popping up for PrEP. So at the intervention specification level, really thinking about patient-centered care in terms of uptake decisions, what choice of modality. So right now there aren't lots of different choices, but as we progress in the with technology, there will be multiple choices for people to make. So just like in the family planning world, there are multiple choices for women to choose from. How do we help people make those choices? Thinking about adherence support and persistence support. And then at the population level, I talked a little bit about some of these, but really what are the communication strategies that work? What's the target settings? Thinking about the health system in terms of logistics and supply chain, human resource planning, M&E and information systems. And then thinking about scale up and using ongoing data intelligence about uptake and population segmentation to really understand how to fine tune a program. And then institutionalization, so really thinking about resource allocation and planning for sustained or optimized sustainment. So really, right now in most countries, PEPFAR is the funder for PrEP. So what does that look like over the next couple of years as it transitions back into government systems? So are we engaging with ministries of finance to think about additional funds for drugs, or are we thinking about additional resources for healthcare workers who we may need to help with this effort? So really thinking about some of those big picture funding issues if we think about PEPFAR pulling back at some point or any kind of donor funding pulling back. So the second one that I wanted to talk a little bit about is ART multi-month dispensing. So this is something that USAID and PEPFAR are pushing very heavily. And what are we talking about in terms of multi-month dispensing? So this is, instead of giving 30 days of pills, it's giving 60 days, 90 days, 180 days of pills. So why would we want to do this? One, we've seen that it improves ART adherence. It reduces transportation costs and time burden for patients. So again, if a patient has to go to a clinic every month to pick up their meds, they have to pay to get to that clinic every month, and they probably lose an entire day of work to go to that clinic. So if we can say, okay, you actually just need to show up once every 3 months or once every 6 months, that's probably a good thing. Again, decongesting the facilities. Any facility that you've been to in some of these developing settings, these facilities are incredibly packed with people. So if we can get fewer people in on a daily basis because they're not picking up their meds every day, then it allows clinicians time to actually work with more complex cases. Reduce costs for ARV procurement due to lower cost of larger pack sizes. So again, instead of giving packs or bottles of 30-day, you can give them 90 days, and we start saving money that way. And at a micro level, it's maybe a couple cents per bottle, but when you aggregate that up to 15 million people who are being funded or getting their drugs through PEPFAR, that's a whole lot of money when you think about it in the aggregate. And then better client ARV access through expedited facility and different external distribution mechanisms. So this point is really, we don't want people to go to the clinic if they don't have to. So particularly in South Africa and a lot of countries, we're thinking about different ways to get the drugs to patients. So it seems like a pretty easy intervention. Just give people more pills. So you want to get a high proportion of stable patients on multi-month dispensing. And for many of those people, you want to try to give them a bigger pill bottle so that they don't have to come back to the facility. So in sort of it seems pretty easy. Obviously, there are lots of policy changes, regulatory approvals, provider training, patient education, and sufficient supply and health worker knowledge. I will say these requirements have been incredibly hard to get through some countries. In South Africa, there was a worry that a shift from 30-day to 90-day or 180-day, there wasn't money for it. And what we were able to do with some modeling was to show you need an initial influx of, I think it was around $7 million to make this transition, and then you reap the benefits of that. But then the question is, who's going to give us that $7 million? So, again, it's a really relatively easy intervention in sort of thinking about it, but it's incredibly complex in terms of how to make that happen. So this is a terrible snapshot of some data. But essentially what this is, again, these are the dates here. So this is June of 2019 going into the end of July. This is looking across, so USAID has, for all of our PEPFAR countries, for the HIV programs, we collect monthly data, so our high frequency reporting. And so these are the percentage of people who are on ART who are receiving multi-month dispensing. And so you see an incline over time. But again, this is the type of data collection that we're really looking at to try to understand how quickly can we make these changes happen. In South Africa, we've been having an incredible hard time making this transition from going right now. It's two-month drugs that patients get. We've had an incredibly difficult time until last week when we got the minister to agree that we could move to 3 months of drugs. And then we're going to be testing in 2 different districts 6 months of drug supply. But again, we have to once we have the permission, we actually have to be able to make sure the drug supply is there, make sure that clinicians in those districts all understand that they're allowed to do that, and that's behavior change, and that's incredibly difficult. So why hasn't the uptake been quicker? Protocols. There's one thing for a minister to say yes, we can do 3-month dispensing. For that message to get down to the pharmacist or the clinician who's writing the scripts, that isn't an easy connection to make. So protocols, again, government's taking a really long time to establish policies, supply chain issues, which I've talked about. Pharmacists think that people are going to lose their drugs, so why would you give them 6 months? They're just going to lose it. Then they're going to have to come back for more. It's going to cost me more. Thinking about patient awareness. If a patient doesn't know that they can get 6 months instead of 2 months, a majority of patients would prefer not to have to go back to the health facility. But if they have no idea about that, then they're not going to ask for it. Not having enough drug supply for all the different patients or for all the eligible clients. And then thinking about sort of situations for children and breastfeeding or pregnant women. How do we think about those special populations? So 2 countries where we've seen a lot of success in moving this forward. Uganda right now. Let's see, when was this? So this was. I think this is data ending in October, but we have over 50% of people who are on treatment who are getting multi-month dispensing. And in Zimbabwe, almost 90% are getting 3 months of dispensing, and about 30% are getting 6 months of dispensing. And this is, again, not over a very long period of time where we've been able to help the government make this transition. So again, thinking about some of those concerns about why this wasn't happening, we really are digging into trying to understand what we can do to make people change their behaviors. So one, let people know how they're doing. So really thinking about optimism bias. But telling people 77% of eligible clients were put on MMD, trying to convince clinicians, trying to convince people themselves in terms of retention, really thinking about social comparisons. All of your friends are taking more meds than you. Why are you lagging? Not why are you lagging behind, but do you want to catch up to them? And then really thinking about provider nudges in Zambia for confidentiality and how that impacts patient uptake of different interventions. So again, this is work, qualitative work that's been happening across lots of different countries. Most of these data are collected by our implementing partners in the field, and this is what we're hearing from them. What are some of the things that are working? Things like stickers to files to know who's eligible or who's not eligible for multi-month dispensing, and also as just a reminder to clinicians that if they see a pink sticker on a chart, it reminds clinicians to talk about multi-month dispensing. Thinking about how do we influence national technical working groups and ensuring that we get the right guidelines and policies out there. Thinking about how do we need to change counseling for folks when multi-month dispensing is an option? Do we need to change the messages in our counseling? Do we need to think about how do we get patients back in for viral load testing when that's a requirement in a country? And then thinking about different technological tools to help both the clients as well as the providers how to move forward with this. So this is the last intervention that I wanted to talk about, it's to say that the right interventions are not always very complex or complicated. So we are very much moving towards a patient-centered sort of way of being. And anyone who's ever been to a health facility in a developing country knows it's the most terrible thing to you arrive at 5 a.m. and then you're still there at 4 p.m. And so one of the problems that we were seeing is filing was an issue. So in one site in South Africa, a Peace Corps response volunteer developed a filing system SOP, and they cleaned the filing room. And this reduced wait times for your file. So you arrive at the facility, you say, I'm here, and someone has to go get your file. It went from 3 hours to get that file to 5 minutes. And if you can, again, imagine what the sort of economic impact of that is, if you can cut down someone's wait time from 7 hours to 4 hours, that makes a huge difference. That increases people's willingness to come back to a facility. I still don't think a lot of us would want to wait 4 hours, but it's better than 7. And this is just one intervention. And so what we saw across several different districts where we've been sort of focusing in on filing systems and file rooms, we've seen a significant increase in the number of patients whose charts were found within 5 minutes. And again, this isn't something that any of you would probably be doing research on, but again, this is the easy fix that we found, and this is something that at an operational level makes a difference in how people experience their encounter at a health facility. So just some final thoughts. Again, I went through this at the beginning, but really the programs need to focus on the right people and the right geographies with the right interventions. And again, it can be as simple as a filing room to as something as complex as sort of all the work that went into identifying the fact that PrEP worked and that PrEP needs to get into people's mouths. And program data and research data drive program implementation and increasingly do so on rapid timeframes. And particularly with HIV, it's completely changed the way we do business in the development sphere. And then understanding, again, how programs are implemented really is critical for research design and whether or not that research can be utilized for implementation. again, so thinking when I did my doctoral work, within 5 years it was almost irrelevant in terms of implementation, and so really understanding how to do this work quickly and well. We don't need a perfect study to make changes in programs, but we do need some data to support the fact that we're going to make changes in the program. But again, one of the things that I tried to emphasize throughout the presentation is that, again, 2016 was the earliest map that I showed here. And again, data from last week. That's almost unheard of in a lot of programs. But increasingly, we're seeing that PEPFAR is setting a model that things like the President's Malaria Initiatives is following. Increasingly, we'll see this sort of creep into the TB programs globally. And so what does that mean in terms of the research that you all do and the timelines that academia takes to really produce work? We have to be thinking about how do we increase the time on that? Are there technologies that we can use that would improve the timelines for things like this? So let me just, the last piece is just some acknowledgments. It's really funny because once you leave academia, citations are something you don't really even think about very much. But I did use work from some of my colleagues, Dr. Delavet Castro at Columbia and my colleague at USAID, Tom Minier. A lot of the slides are their work as well. So thanks.
Thanks so much. So I think we'll open it up to questions. Sheila.
Hi, thank you for a great talk. I work at Case and Ed, and I'm very familiar with some of the data issues that you mentioned. And I'm just wondering if you could comment on some of the data quality issues. You talked about being able to access data in more real time and acting on that data in real time. But I'm realizing, from my experience with around, and I think there's been several papers on this, including from our group, about the level of the quality of the data in tier.net at the primary care level, and the ability to act on that for planning purposes.
Great. Yeah, data quality is huge. I mean, you can probably, there's one slide that I showed of the multi-month dispensing, and even just the visual, you can tell that there's probably data issues there. But in South Africa, one of the major things that we have challenges with is that there's not a unique identifier, and people are highly mobile. So you initiate ART in one clinic, and then a month later you're working in another area, and you go back to another facility, and they start a brand new chart, and you just get a new ID number in the system. So it looks like we have a gazillion people on treatment, and then we have a gazillion -1 people falling off treatment. And so understanding, how do we correct some of those data issues? And those are easy technological fixes. There are lots of health systems that are able to do that. But it's incredibly complex when you're working, South Africa, and I don't think South Africa is an outlier in this, but lots of different systems that have been developed over multiple years, over multiple government administrations in South Africa, multiple funding priorities of international donors, and you have a system that has sort of 5 mini components. So, in South Africa, the tier.net system, which is the patient sort of system, doesn't talk to the lab system. So being able to connect someone getting a viral load in the national lab system doesn't connect to their actual patient file, which doesn't make sense at all, but it's developed by 2 different developers over different time periods. We think about human resources for health. That also doesn't connect in to sort of a broader health system response information system. So we as PEPFAR, we can't tell, how many clinicians PEPFAR is funding for versus the government is funding for in all of our sites. So we can't tell if we send in a PEPFAR nurse if a government nurse leaves, and we just essentially replace that, which is not what we want to be doing. We want there to be a full complement of government workers, and then PEPFAR sort of tops up that program. But the data quality issues are significant, but we're constantly thinking about fixes. Another example is in South Africa, there's a program called the CCMDD, which to be honest, I can't even remember what the acronym means, but it's essentially you can pick up your drugs outside of the facility. But what was happening is if you become eligible and you stop going to a facility because you're now picking up your drugs at a clinic or a drugstore in your community. If there wasn't one tick box that was marked on your file, you would in the government system, you would look like you fell off treatment. You were lost to follow-up. Whereas you were actually still active, you're getting all your meds elsewhere. So PEPFAR was wondering, oh my God, we're losing all these people, what's happening? And it was simply clinicians weren't putting a checkbox. And so when the data entry clerks were putting it into the system, they would just disappear after not showing up for 3 months. And so that was training, going back out and making sure all our partners were training their clinicians and their nurse staff to make sure you check that checkbox so that we know they're picking up their drugs in another place. And now there's been another system that was developed to make sure to understand how many parcels of drugs were actually picked up from the community sites and sort of linking that back. But again, that system doesn't talk to the tier system. And so again, you have all these sort of the patchwork of systems where, in South Africa, we're hoping that at some point the government will just say, okay, let's just completely redo this and start from scratch and develop the system that is where we need to be in 20 years from now. We got a price tag for that, and it's not something that we could ever afford. But it is, we're moving in that direction of trying to figure out. South Africa is a country that probably has some of the best information systems and probably the most sophisticated health system on the continent. But these are all issues. And so you think about what's happening in Swaziland or Lesotho or Namibia, some of these challenges are incredibly immense.
Along those same lines with the data, we have many similar issues here in the US, but you mentioned data entry clerks, to get that up-to-date data. Are these folks that work for PEPFAR? Are they employed by the clinic? Or how do you get data moving so quickly from each of these multiple clinics?
Yeah, so data entry clerks are, I don't know if they're an official South African sort of cadre of a healthcare worker, but we as PEPFAR fund a lot of these folks who essentially will take the paper file after a clinical encounter, and we'll enter it into the tier system. And what we see is essentially these clinics are incredibly busy, and you end up having piles of files that need to be entered into the system. If you have if you're understaffed at a facility, data entry isn't the most critical piece. And so that was something that we were seeing. And so the data entry clerk cadre was sort of introduced among at least PEPFAR partners so that we have someone whose their only job is to take the files and put the information into the system. Because otherwise we lose those files, or they get refiled, and in the system they look like they're gone. But increasingly, we've been at that. PEPFAR has been at this in South Africa for 17 years now. It's not good enough for us to say, oh well, we don't know if our numbers are good. So at this point, the numbers that we have in terms of patients on treatment, patients that we're losing, we have a pretty good sense that they're real people that we're either keeping or losing from the treatment goals.
So could you talk a little bit about human resources? You mentioned a little bit, but I mean, almost everything you talked about kind of requires health workers to be adaptable and deliver. And I mean, I just think in the literature, it's not always touched on. And just on the ground, I think we hear a lot of stories, at least in the TB world. And I think you can comment on whether it's the same in the HIV world, just about mistreatment of patients and just these types of attitudes that make it really challenging to achieve a lot of the goals that you mentioned in terms of patient-centeredness and retaining people in care. And how does USAID think about some of those human resource issues kind of broadly? Sure.
So just in thinking about in terms of sheer numbers, so in South Africa, I think this current fiscal year, the budget envelope for PEPFAR was about 725 million. I want to say about 300 million of that is just for human resources. So I think it's over 20,000 nurses, physicians, pharmacists, lay counselors, data entry clerks, administrative staff, not at our partners. These are people who are essentially government workers, but just paid from PEPFAR roles. So in South Africa, I think this past year, I think we got up to about 16,000 that we actually hired in. So it's just the number of health workers is a huge issue. And we know that the government can't afford this themselves. And again, South Africa pays for 80% of its health response, of its HIV response. PEPFAR is about 15-20%, and Global Fund makes up the remainder. But just last week or 2 weeks ago now, we heard that historically in South Africa, the health budget has been a protected budget. So you can, other ministers can try to poach off of it, and it's no longer the case. It's not a protected budget line anymore. So the announcement that we were told by the minister was essentially that they're going to have to decrease salaries for all healthcare workers across the board because they can't afford to keep everyone on at the same price, essentially. So PEPFAR has committed to continuing to fund the healthcare workers that we have there now. In terms of mistreatment of patients and just client-centered care, this is a huge problem. I mean, we think about, a lot of the programs that I oversee are related to key populations and young people. And we talk about adolescent-friendly services. We talk about gay male-friendly services. We talk about sex worker-friendly services. And at the bottom of it, you want friendly services for everyone, right? You want, patients want to walk into a clinic and not be yelled at. They don't want their medical information being talked about with everyone. And that is, some of it is just pure training of clinicians. But some of it is also, there are policy issues as well related to this. And then again, this just came up last week or 2 weeks ago, where we have civil society monitors who go out to different facilities and try to understand the experience of clients. And they took a picture of sort of a flyer that was on a wall that essentially said, by the National Department of Health Policy, if you defaulted and so you missed picking up your drugs last time, you have to go to the end of the queue. And it's like, okay, so you missed getting your drugs for whatever reason, and we want you to come back. We want you to come and get your drugs. That's a good thing that someone says, okay, actually, you know what, I need to go get my meds. And then we have them come, and then we tell them, okay, but you have to go wait at the end of the line, so we'll see you in 8 hours from now. And it's like, well, that person's never coming back again. I mean, and so that was something that we raised with the Department of Health and said, can we please correct this policy if this is in fact a policy? And if it's not a policy, can you clarify, because we're seeing this across multiple facilities. So it really is trying, what we've been doing increasingly over the last year and moving into the future is, in terms of client-centered care, is really getting civil society involved and raising red flags to us and to the government around what people are experiencing in facilities.
One thing that you said that struck me, and then something on a slide that you didn't say but was around the fact that if you collect all sorts of data but don't make use of it, that it's a tremendous waste of resources. And I would imagine that all the data that's being collected internally, you can't possibly ask and answer all the questions you'd want to. And the second thing that was on the slide that said innovative use of secondary data. Are there opportunities to partner with people, say, in this room to get access? I mean, are you inviting data sharing opportunities? So you mentioned CCMDD, and I'll just say, CIRA and Erica are leading a project looking at CCMDD and evaluating that, and we've had trouble accessing some data through USAID and others. And are there ways of trying to make sure that that there are opportunities to partner and help ask and answer questions that you would be interested in, and making use of the data that you have?
Sure. So first around the data utilization piece. So again, South Africa is very much at the edge of the curve in terms of not every, most countries within PEPFAR are for USAID are collecting monthly data. South Africa, Mozambique, I think Nigeria, and a few other countries are really collecting daily or weekly data. So not every country has the level of detail that we have for South Africa. And again, I think PEPFAR, I think in the country there's over, I think 3,300 health facilities. PEPFAR works in a subset of those, and then we collect data in the highest burden of those, and it's about, I think I said about 425 we're at now. But so those weekly data, I showed some of the visuals, but we get that every week at headquarters. Every week there's a call between the National Department of Health, USAID, and implementing partners. And moving forward, part of that call will also be civil society. So on a weekly basis, they're looking at these data at the national level. In South Africa, at the district level, depending on which, in the highest burden districts, we also have weekly calls with heads of department and technical staff to dive down into facility level issues. So we have trackers that look at a facility level, sort of what are the bottlenecks, and it really is meant to sort of bring things down to the absolute sort of most minute level of what is the bottleneck and how do we resolve it this week or next week, right? And this isn't like, oh, well, we're not paid enough as staff. Well, okay, we're not going to resolve that. We're not going to talk about that. We're not going to address that. But what we can address is, this is the experience that we've heard from several clients. Why is that happening? How do we address that? Do we need to redo it? Do we need to do a retraining on counseling services? What is it? Do we need to? Is the file room a mess again? Do we need to sort of resensitize people to the filing SOPs? It was, was the data entry clerk sick for a week, and so there's a week of data missing. How do we get back on track? So it really, I don't think we use all of the data, but it's pretty impressive when you get the government on board and can get a good facility manager. When you see, skyrocketing numbers of people on treatment, part of that is, one, we're just doing the job better, but people are staying on treatment because the services are getting better. In terms of inviting data sharing, so I'll caveat this by saying all of the data that we're looking at is not US government data, right? We share it with the South African government. So there are, in South Africa, actually, I think a lot of countries are like this, but South Africa is not always in the sharing mood. So it can be very difficult to get some of these data.
That's why I was asking.
Yeah, so PEPFAR has increasingly moved to be more transparent. So a lot of the weekly data that we collect isn't publicly accessible. All of the sort of quarterly data is all in the public domain. So PEPFAR.gov, any quarterly data or annual data that's reported. So I imagine already last year's data are available. So in at the end of September 2019, any data up to that point should be available on sort of PEPFAR key indicators. Some of the more frequent data, like the USAID high frequency reporting data, that's all internal. That comes from partners and then goes directly to USAID. And even that, it's probably it's not high quality enough that it would be usable in terms of publications or really analysis in that way. But yeah, I think if people are interested, happy to talk more about the types of data that might be accessible. Obviously, if people do have ideas about or research questions, but just can't get the data, part of it is, okay, let's raise this with the right people in South Africa or whichever country people are working in to get access to that data and see what kind of questions we can answer with it.
Building on the data theme, the evidence that you found regarding the treatment holiday, was that something that I'm sure clinicians were aware that was happening on the ground, but were they aware of the scale of it before the data became available to this mass collection of data?
Yeah, I think everyone who works in, literally December 15th or a couple of days, the whole country shuts down. No one works or functions or like trying to get anyone to do things during that period. And because everyone travels home. And so we know it happens. you know, it's a pretty stark visual to see something like that and understand that that's a problem. And, you know, it's one thing to talk about things anecdotally, but then when you're faced with the data, it can drive decision making. And so, you know, we can show that to the governments and say, okay, can we start playing around with how many pills that we give people around this time? Can we be creative about, you know, giving people treatment, giving their treatment from a facility where they're not registered? How do we think about some of these potential solutions?
I imagine this is not just HIV though. Everybody's going to
Yeah, no, absolutely. Yeah.
chronic diseases of all kinds.
I mean, the visual is actually very surprising, just from colleagues and working, at least in KZN, it's a very common practice for November to give people 2 months supply. So I'm just surprised that doesn't seem to be a nationwide practice. And I don't know if this is like.
Yeah, so I'll go back to that slide, but that's among our let's see, among the sort of the get there first. So this is among about 425 facilities. So, you know, part of this may be again a data entry piece, right?
Yeah, the documentation is not reflecting practice, which is something that we run into daily. And I know that's obviously on your radar. I just don't know if this is different by province or by district.
I'm sure it probably is. There's pretty significant variability. But the other interesting thing about here is the green line is the biweekly target, and you can see it's almost never met. I mean, again, this is the drive to get to 90-90-90 in South Africa. So again, that's about 6.1 million on treatment by the end of this year. So in order for us to hit that target, we need to be hitting those green lines, and we're not there.
How do you come up with those targets? And you know, to what degree? Because we've had a few people come from countries and just say, you know, they find this a big challenge and they don't believe them. And I know it's very hard to know this. So how do you guys think about that?
So we blame UNAIDS, but it is. I mean, a lot of it was a sort of the initial piece was really thinking about epidemic control and where's the tipping point. So a lot of it is modeling work. But you know, we had the WHO 3x5. That was sort of, you know, the last generation of this type of work. But now even 90-90-90. I think I took the slide out, but what we're actually aiming for is 95-95-95. Because you know you need that 90-90-90 among every single population, and when you aggregate that, it becomes 95. But yeah, I mean, it's a political goal, right? But it's also, you know, we see this even within the HIV world, that we have these treatment targets, and it gives a good talking point. It gives a good goal to have. It sets the numbers. It sets targets. We don't have an equivalent in the prevention world, and it's been incredibly difficult, sort of motivating resources, understanding achievement on that side of the equation. So it has been something really useful in terms of, because you can, and what we are really doing now is breaking that down. You know, we have these UN targets that come out of Geneva or Washington, but what does that mean at Esalen Clinic in Johannesburg? What does that actually mean in terms of what your job is as a nurse who can initiate people on HIV treatment
Today.
Yeah.
First of all, thank you again for coming. This is an incredible presentation, and what you're doing with data is dazzling. Several people have asked about data, and I want to sort of re-raise that issue. I've tried to work with PEPFAR for decades. I mean, you know, and the original legislation used to preclude explicitly research, and that's changed. But the reality is, what you're presenting is, as dazzling as it is, it's sort of an M&E kind of perspective, and the people in the room tend to have different types of questions, and you alluded to it. Timeframes, responsiveness, you know, we know those tensions, okay? So that's just different worlds, right? So the question is there something we could do structurally or organizationally where we worked on a more consistent basis with you to either understand your priorities or the opportunities, or to build trust and relationship, you know, sort of more of a public-private partnership? Is there, you must think, you were very gracious, but you encounter these kinds of requests every day. And you're going at 200 miles an hour. Is there a way to build in sort of more of a programmatic approach to this that would make some of these issues easier to address, be more complementary to what you're trying to achieve and so on?
Yeah, so within the PEPFAR world, again, for folks who have been sort of interfacing with for a long time, there really has been this sort of ebb and flow of, you know, can we even mention the word research in the context of PEPFAR? And even now, we don't really talk about research very much. And part of that is this notion that research takes too long, and that we're moving too fast to be thinking about research. And to a large degree, it's true, right? You know, we spent almost $100 million on 3 prevention trials. One was looking at treatment as prevention, and global guidelines blew through the timelines for that study. I mean, this is 3 studies. This is $100 million. I mean, we learned a lot from the studies, but the ultimate question around treatment as prevention, I mean, that, I don't want to say it was a waste of funding, but, you know, we learned lots of things, but the nugget of what we were looking at, it was just taking too long, and global guidelines overtook it. And so you find the other pieces of information that you learned from it. And so, you know, part of it is, you know, I think about how long does it take to get an IRB through, and, you know, probably here, hopefully, it can move pretty quickly, but then, you know, you go to the, you know, the South African MRC and try to get an IRB approved. You go through even CDC to get an IRB. I mean, these are huge amounts of time, and that's just one little piece in.
So I'm 100%, you know, our pilot grants, they're done by, we don't get money by the time they're done because we can't get higher approval here and we can't get higher approval. I guess what I just, and it's too complicated a question for today. I really like just to raise it. Can we do a better job, either programmatically or structurally, or think about a way so that we can be ready to do things, answered pointed questions, you know, because there is useful research that can come up with answers in a reasonable time frame.
Yeah, no, absolutely. You know, I think one of the things, and you know, there's sort of program people and there's academics, and then there's a small range of people who are in the middle who really understand both worlds. And it's really finding those people who can sort of have one leg in sort of each world and making sure that those bridges are built. I would love to have, you know, the terrible thing about working for the government is that, like, you can't easily just get an intern or a graduate, you know, a doctoral student to just come in and work on a you know, project. It's just difficult. But there are, you know, we don't have enough people thinking critically about programs and thinking methodically about programs. And there's a real value to that. But those skills are useless if there's not a grounding in, you know, how things are actually done at a facility or within a health system. And so it is finding people who can bridge those worlds. And, you know, I was saying earlier, you know, the people we tend to engage with are people at Johns Hopkins a lot, the people at George Washington, and it's because they are also the schools where we have lots of adjunct faculty who work at USAID, because it's, you know, a half hour away or 45 minutes away. And so the challenge, I think, for a school like Yale or wherever, whichever school, is how do you get people involved to sort of have one foot in that program world. And so how do you bridge the, you know, the folks who are really sort of understanding and making budget decisions and making program decisions in the field? How do you get them to sort of engage with a group like this? But it's challenging, and I don't know what the answer is. But it definitely is. There are skill sets on both sides that need to be better bridged.
just to get to my first point, so, and Erica's the PI for Yale's role in evaluating Project Last Mile, which is active with the CCMDD program. But I think what I'm hearing also is that there's evidence from the field from good program implementation that might not be making it into evidence. So beyond, evidence is taking a long time to generate from the academic side, but they're already grabbing evidence, just like the guidelines were cascaded. So how do we, maybe academia has a role in distilling those lessons up back into evidence, because we're already seeing it working on ground. So how do other countries, other settings actually adopt those practices?
Yeah, I don't know. I think about how we, even within PEPFAR, how do we think about sort of when things are going really well in a particular country, how do we get that information to other countries? Because they're all grappling with similar bottlenecks, maybe at different time points and things like that. But part of it is is just internally, how do we share information? So a lot of it's how do we manage knowledge? How do we disseminate that knowledge? How do we make sure it's getting to the right people? But a lot of it is you can't we've with all these data we've moved away from sort of anecdotal, we think this is a good idea. I mean, we are able now to implement an intervention and have the data over time very quickly, thinking about the demand creation for PrEP for MSM. I mean, we can do that for lots of sort of micro interventions in terms of changing uptake of different interventions. I think one challenge is there's not a lot of academic journals or journals that are willing to publish any of this kind of data, right? There's no IRB on any of this. This is so there are maybe 2 or 3 pretty good practice journals that don't require that level of IRB approvals and things like that. But until there's sort of more of an emphasis on different data sources and the ability to publish on those data sources, it's really hard to get out there and sort of in this more academic setting.
Well, Tim's going to be around, I think, a little bit this afternoon, meeting with some of you all. But thanks, and I think we have a little bit of time after people want to come up and ask some questions. Really, thank you so much for giving us insight to what you guys are trying to do. And I think this really inspiring model of using data and using it quickly. I mean, I think I definitely felt energized by that idea and saw a lot of ways for kind of applying it, and hope we can keep the conversation going. I think Paul and Mayor and others had some really kind of interesting ideas, and keep trying to figure this out. This is really, really important, I think, for both sides to kind of move forward in the epidemic. And thank you again for taking the time to come. It's really great.
Great. Thanks for having me.